Good morning. This is Dr. Deepti, Senior Lecturer from the Department of Conservative Dentistry and Endodontics, Sri Balaji Dental College and Hospital. So today I'll be talking about non-carious tooth lesions. So there are, apart from caries, there are other non-carious process which can cause loss of tooth structure. So the non-carious tooth lesions are of four types. They are attrition, abrasion, erosion, and abstraction. We will see about each one by one. So the first comes attrition. Attrition is the loss of tooth structure or tissue which is caused due to tooth-to-tooth contact. Which is caused due to tooth-to-tooth contact. The dental attrition is defined as the physiological wearing of the teeth resulting from tooth-to-tooth contact as in mastication. This is an age-related process that can occur at incisal or occlusal surface and sometimes on proximal surface. Reverse cusp is seen in severe cases. So here this is a picture showing attrition of the upper and the lower incisal teeth. Now you can see there is a loss of tooth structure, there is loss of enamel, and you can see the dentin exposed. So here is an image of a healthy tooth. Here is an image of attreated tooth. So these are attreated occlusal surface of molars. So here you can see reverse cusp. So attrition is generally an physiological process. It is an age-related process. However, attrition can be accelerated by eating hard and abrasive diet, by having parafunctional habit, bite malalignment, and also developmental defect. In these cases, attrition can be rapidly accelerated, and hence it becomes a pathological process. Coming to the clinical presentation, the attrition in its purest form is seen as flattened occlusal surface. So here in this image, you can see the upper and the lower incisors having flattened occlusal surface. So in the previous slide, you can see the molar having slight flattened occlusal surface. The degree of wear in both arches are normally equal. Sometimes there may be a presence of peripheral ragged sharp enamel edges. So in this picture you can see lower incisor teeth with peripheral ragged sharp enamel edges, and almost the enamel is almost gone. Only the periphery there is a ragged sharp enamel margins. The pulp is almost exposed in this picture. Then the presence of hypertrophic masseter is a warning sign of impact of bruxism. So if you find a patient with an hypertrophic masseter and severely attreated teeth, then there could be an indication of patient having parafunctional habit, which is bruxism. So here is an image of an hypertrophic masseter. When the surface of attrition is lower and compensated by intrapulpal deposition of secondary or tertiary dentin, then there will be no pulpal exposure. So if the attrition is lower than the amount of secondary or tertiary dentin deposited, then there will be no pulpal exposure. At other times, the attrition is faster than the intrapulpal dentin deposition, leading to direct pulpal exposure. In some cases, if the attrition is faster than the amount of tertiary dentin deposited, then it can lead to pulpal exposure. So here you can see a deciduous lateral incisor with almost a pulpal exposure. So you can see a pulp here. If the attrition takes place rapidly, if the loss is severe, then generally then there will be loss of vertical dimension of the tooth, and this loss of vertical dimension is accomplished at a relatively short period of time. So this sudden quick loss of vertical dimension can cause strain in the stomatognathic system. This can cause discomfort to the temporomandibular joint and as well as to the muscles of mastication. The other consequence of attrition are, so see, the first consequence of attrition is the loss of vertical dimension of the tooth, and that too accomplished in a relatively short period of time. This can cause strain in the stomatognathic system, that is discomfort to the temporomandibular joint as well as to the muscles of mastication. The other consequence of attrition are deficient masticatory capabilities, such as, see, the blunting of cusp may compel the patient to apply more force on the teeth. Here you can see a treated occlusal surface of the posterior teeth. You can see blunted cusps. Uh, Next, other consequence is cheek biting. The vertical overlap between the working inclined planes will be lost, which will cause the surrounding cheek, lip, and tongue to be fed between the teeth. So here you can see normal teeth without attrition. In an attrited teeth, the vertical overlap between the upper and the lower posterior teeth will be lost. So here you can see upper and lower attreated posterior teeth, and you can find a gap here. The cheek, lip, and tongue may be fed in the gap between the teeth, and this can lead to cheek biting. Then decay, because the underlying dentin will be exposed, and therefore it will be the tooth will be more susceptible to decay. And also tooth sensitivity, because of the exposed dentinal tubules. Since the dentinal tubules are exposed to the oral cavity, the treatment depends upon the following categories. The category 1, category 2, and category 3. Category 1, if the appearance is satisfactory. Category 2, if the appearance is unsatisfactory and there is a need to raise the vertical height. Category 3, the appearance is unsatisfactory and there is a need to raise the vertical height, which in turn depends on availability of space, whether it is present or it needs to be created. Okay, so first is the category 1. In category 1, there is only mild attrition. The appearance is satisfactory and we don't increasing the vertical height is not required. See, the first line of treatment for non-carious tooth lesion is to remove the causative factor. So we have to counsel the patient if he is having any parafunctional habit, if the malocclusion has to be corrected. So the habit breaking appliance should be given in patients with a bruxism or a clenching, followed by this is followed by a conventional restorative treatment. If there are any exposed pits, it can be filled. The second category is the appearance is unsatisfactory, but there is no need to raise the vertical height. Teeth are restored preferably with all ceramic crowns or laminates. So in this picture, you can see an untreated 3, 4 and 3, 5 tooth preparation done in untreated 3, 4 and 3, 5, and it is restored with crowns. The crowns can manage occlusal attrition as well as fractured cusp. The occlusal guard for protection against nocturnal clenching, nocturnal clenching. So here the patient has to be given occlusal guard to protect the teeth from nocturnal clenching. The category 3, in this category, the appearance is unsatisfactory and also there is a need to raise the vertical height. Here the amount of vertical dimension loss is estimated and it has to be replaced. So they can be of two types. One is there could be a generalized loss of vertical dimension, or there could be localized, only in a localized area VD has to be, vertical dimension has to be increased. So in a generalized loss of vertical dimension, generalized increase in a vertical height is required. The amount of vertical dimension lost is estimated. It gives an estimated up to what should be the height of the wound crown, how much the clinical crown which we are going to replace has to be increased. Then coming to the doll concept is used when there is a localized, when we have to increase the vertical dimension in a localized area. So it is used in cases of localized tooth wear. It is a method of gaining space in cases of localized tooth wear where there is sufficient space available either in centric relation or centric occlusion. So here in this image, see, we want to gain space in a localized area. In that cases, doll concept can be used. Okay, it is used in cases of localized tooth where we need to gain space in a localized area. It was described by Dahl and his co-workers in the year 1975. Partial bite tracing appliance is used to create the interocclusal space in an 18-year-old patient with severe localized attrition. So Dahl, he created a partial bite tracing appliance in an 18-year-old patient with who was having a severe localized attrition. The patient had to wear the appliance for 24 hours a day. After a period of 8 months, after sufficient space was created to restore the upper anterior teeth, the teeth was restored with full coverage porcelain bonded crown. To ensure that the patient is able to tolerate the increase in the vertical dimension, it is necessary to wear the appliance for at least 6 to 8 weeks. So what Dahl did is he gave an partial bite tracing appliance. So in this case, in this image, you can see he gave an anterior bite plane and he made the patient wear it for at least 8 months. So by giving anterior bite plane, the posterior teeth, after 8 months, the posterior teeth, see, they were not in occlusion initially. After 8 months, the posterior teeth they came in occlusion, and in the anterior region you get a space, and that space was utilized, and it was restored with the full coverage porcelain bonded crowns. So after 8 months, sufficient space was created, and it was restored after 8 months, sufficient space was created to restore the worn upper anterior teeth. Coming to abrasion. The abrasion is a process of scraping or wearing away something. Abrasion is defined as a surface loss of tooth structure resulting from direct frictional forces between the teeth and the external object. Attrition is loss of tooth structure due to tooth contact, whereas abrasion is the loss of tooth structure between teeth and an external object. Sometimes it is a pathological process. Sometimes the abrasion rate is faster than the amount of dentin deposition rate. This can cause direct or indirect pulpal involvement. The abrasion can affect one teeth, it can affect multiple teeth or an entire dentition. Any surface of the tooth may be affected, but the frequently affected site is the cervical region. So attrition is loss of is tooth wear, which is caused due to tooth contact, whereas abrasion is tooth wear, which is caused due to frictional forces between the teeth and the external object. Causes, a main cause for most common cause for abrasion is improper brushing technique. Other causes for abrasion are occupational habits such as holding bobby pins in between the teeth, tobacco chewing or tobacco pipe, vigorous use of toothpicks between the adjacent teeth, excessive mastication of coarse food, dentures with porcelain teeth occluding with natural teeth, ill-fitting metal clasps or dentures. So here you can see a girl who's opening hair clip using her teeth, and you can see abrasion here in the incisal edges of the upper and the lower incisal teeth. Here you can see abrasion in the cervical region and the buccal side of the canine and the premolar, which is caused due to improper brushing technique. So the main common cause for abrasion is improper brushing technique. So here you can see toothbrush abrasion. It resulted in an horizontal cervical notches on the buccal surface. And even the radicular dentin and the cementum is exposed. In the second picture, you can see notching in the right central incisor caused by improper use of bobby pins. Coming to the clinical presentation, the surface of the lesion is extremely smooth and polished, and it seldom has any plaque accumulation or caries activity in it. So here you can see abrasion, generalized abrasion. You can due to improper tooth brushing. The surface is extremely smooth and polished. It has no plaque accumulation or caries activity in it. The periphery of the lesions are angularly demarcated from the adjacent tooth surface. Probing or stimulating the lesion can elicit pain. Hypersensitivity may be present. Why hypersensitivity is present? Because dentin is exposed. Dentinal tubules are exposed to the oral cavity. Hence, hypersensitivity may be present. Coming to the treatment modality. The treatment modality, first the cause has to be removed. We have to identify the cause of abrasion and we have to remove it first. It could be improper oral hygiene techniques, habits, etc. So first diagnose the cause of the presented abrasion. A detailed history has to be taken to diagnose the cause. It can be due to oral hygiene technique and habits such as pipe smoking, chewing tobacco, and professional habits. Instituting proper oral hygiene measures. So the patient has to be advised on proper oral hygiene measures and judicially toothbrushing with an dentifrice, incorporating correct method of toothbrushing. Have the habit of chewing tobacco, toothpick, etc. to be discontinued. Correcting or avoiding ill-fitting metal clasps or denture. Correcting or avoiding the ill-fitting metal clasps or dentures. If successful in breaking the habit, proceed with restorative treatment as planned. So first we have to remove the cause of the presented abrasion, and the second line of and the second treatment is restorative treatment. See, the patient has to be advised on a correct brushing technique, that is a modified brush technique, and the timing of brushing. The patient should brush only for 2 minutes, not more than 2 minutes or not less than 2 minutes. So after on identifying the causative factor of abrasion and counseling the patient, restoration is indicated. The abrasive lesion can be restored if caries is present, if the patient is having sensitivity, if the lesion is aesthetically objectable, if the defect contributes to periodontal problem. So if caries is present, so restoration can be done if if caries is present, if there is sensitivity, if the lesion is aesthetically objectable, or if the defect contributes to periodontal problem. If the lesion is like a wedge, if the lesion is like this, like a wedge V shaped, and the lesion exceeds 0.5 mm into the dentin, then the restoration has to be performed. The common restorative material which are used for restoring abrasion lesions are glass ionomer cement, resin modified glass ionomer cement, polyacid modified composites, and composites. Then coming to the third type of tooth wear, non-carious lesion, that is erosion. Erosion is the loss of surface tooth structure by chemical action in the continued presence of demineralizing agents such as acid. So attrition is tooth wear which is caused due to tooth-to-tooth contact. Abrasion is tooth wear which is caused due to tooth and an external surface, whereas erosion is loss of tooth structure by a chemical action, that is by continued presence of demineralizing agents, which is an acid. So the causes for erosion can be extrinsic or intrinsic. Extrinsic is environmental or occupation, such as wine tasters, swimmers, etc. Diet such as um, 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 continuous use of drinking soft drinks, acidic food, the medications such as vitamin C and mouthwashes. Intrinsic is endogenous, such as a gastric reflex, esophagitis, hiatus hernia, increased gastric pressure, neuromuscular diseases, vomiting, such as psychosomatic, anorexia, bulimia, drug-induced, and regurgitation. Erosion is loss of tooth structure by chemical action in presence of a continued demineralizing agent, that is acid. So what happens is when there is continued presence of acid in the oral cavity, the critical pH, the pH of the oral cavity drops. The critical pH of the oral cavity is 5.5. If the pH of the oral cavity drops below 5.5, then demineralization of the tooth takes place. If there is if the oral cavity has a continuous pH of less than 5, then a demineralization of the teeth is more than a remineralization, resulting in loss of tooth structure. So in all these extrinsic and in intrinsic cases, there is a presence of continued presence of acid in the oral cavity, leading to erosion. In intrinsic causes, our stomach has hydrochloric acid during gastric reflux, vomiting, or regurgitation. The stomach acid enters into our oral cavity, leading to a drop in pH of the oral cavity, resulting in erosion. Clinical presentation, erosion can be on both the facial and the lingual side. Shape, they are broad and they are saucer shaped. The margins of erosive lesions are not well defined. Enamel surface is smooth and polished. The teeth affected, many teeth may be affected. Usually the lingual surface of maxillary anterior teeth. So here are images of erosion. So here you can see the erosion in the lingual surface of the maxillary anterior teeth in an bulimic patient. Here erosion on the labial surface. On the labial surface, on the buccal surface, erosive lesion. Here you can see erosion on the occlusal surface in a patient having gastric esophageal reflux disease. A protocol for prevention of protocol for the prevention or progression of erosion: diminish the frequency and severity of the acid challenge, reduce the amount and frequency of the acidic food or drinks. The acidic drinks should be drunk quickly rather than sipped, and use of straw reduces the erosive potential. And treating the underlying medical disorder or disease such as GERD, anorexia, bulimia, the patient, we should need to refer the patient to a physician or a psychologist. As I mentioned before, first the causative factor for the tooth wear has to be identified and they have to be treated. In case of erosion, the dietary counseling to the patient has to be given in case of extrinsic causes. In case of intrinsic causes, the underlying medical disorder or a disease has to be identified and the patient has to be referred to a physician or an psychologist. Then saliva provides buffering capacity, then increases with salivary flow rate. So stimulation of a salivary flow, sugarless lozenge or candy gum is recommended. And then we can enhance acid resistance of the teeth. And remineralization and rehardening of the tooth surface by fluoride treatment. The patient can be prescribed daily use of a topical fluoride at home, or fluoride application can also be done in office 2 to 4 times a year. Fluoride varnish is also recommended. And then decrease abrasive forces, use of soft bristle toothbrush, and you have to brush gently. So in both for abrasion, generally in patients with the tooth wear, the patient should be advised to use a soft bristled toothbrush and the patient is advised to brush gently. And then and the abrasion can be the erosive lesion can be restored. Similarly, if it has any caries, if the sensitivity is present, if the lesion is aesthetically objectable, or if it contributes to periodontal problem, or if the lesion exceeds 0.5 mm into the dentin, in such cases restoration is performed. So mostly metallic restorations are preferred, since these restorations are more resistant to erosion. Tooth color material may also be used with minimal or no tooth preparation, with the assumption that the restoration may require periodic replacement. So tooth colored materials can be given to patients having erosive lesions, but they may require a periodic replacement. Then coming to the final type of tooth wear, and that is abstraction. Some author explain abstraction as a formation of cervical wedge-shaped defect by the heavy force in eccentric occlusion, resulting in flexuring or bending of teeth. So in this is abstraction is then a wedge-shaped defect present in the cervical region. Here you can see in this picture, in this image, you can see a wedge-shaped defect in the cervical region of 14, 15, 16. The abstraction is caused due to heavy force in eccentric occlusion, not in centric, in eccentric occlusion, results in a flexuring or elastic bending of the tooth. The cervical wedge-shaped defect or abstractions are caused by strong eccentric occlusal forces. It is caused due to excessive occlusal stresses. So these are wedge-shaped defect in the cervical region of the tooth, and they are caused due to excessive occlusal stresses in the eccentric occlusion. This causes a flexuring or bending of the tooth, resulting in abstraction. Only a single tooth may be affected, leaving the neighboring tooth uninvolved. Or many teeth may be affected. More number of teeth are affected in patients having parafunctional habits such as bruxism. These lesions can progress around the existing cervical restoration and can also extend gingivally. So here you can see the features of abstraction, and they are usually present facial. The tooth may be affected or single or overlapping wedge-shaped lesion. The margins of the lesion are sharp, and they may have a corrugated appearance. So the cause of abstraction is when the tooth is loaded along the long axis, the force are dissipated with minimal stress to the enamel and dentin. See here in this image, you can see the tooth is loaded along the long axis, normally directed occlusal forces. In these cases, the force are dissipated with minimal stress to the enamel and the dentin. If the direction of the force changes laterally, like what you see in this image, then the teeth is flexed towards both the sides. So here you can see the a force applied on the cuspal incline. On one side there is compression, on the other side there is a tension. On the lingual side there is compression, on the buccal side there is tension, leading to abstraction on the buccal side. So abstraction is caused mainly due to eccentric heavy force in abstraction, mainly caused due to heavy force in eccentric occlusion, leading to flexure of teeth. Management. So first, the cause of abstraction has to be determined and removed. The occlusal adjustment has to be done. The occlusal adjustment may involve altering the cuspal inclines, reducing heavy contacts, removing premature contacts. Occlusal splint, they are aimed at reducing the amount of nocturnal bruxism and non-axial tooth loading when constructed properly. Restorations can be restorations can be done if there is decay, if the lesion is more than 0.5 mm into the dentin, and if the aesthetic demands are of concern, and the patients are having a dentin hypersensitivity. The abstraction lesions are usually restored with glass ionomer cements, composites, resin modified glass ionomer cement, and the polyacid modified composites. So here in this image, you can see an abstraction defect in maxillary incisor. The enamel margins are beveled and the gingival retraction cord is placed. Acid etching is done. Dentin bonding agent is applied and the tooth is restored with composite. So here a final image showing attrition. So I like to conclude and I want you all to remember that all these are non-carious tooth lesions. The non-carious tooth lesions are attrition, abrasion, erosion, and abstraction. Attrition is caused due to tooth-to-tooth contact. Abrasion is caused due to frictional forces between the tooth and an external surface. The most common cause for attrition is malocclusion and parafunctional habits such as bruxism. For abrasion, the most common cause is improper brushing technique. And then the third is erosion. Erosion is a tooth wear which is caused due to chemical dissolution of the tooth, that is mainly acid. And abstraction is caused due to heavy occlusal forces on eccentric and extrinsic occlusion, which can cause a flexuring of the teeth leading to abstraction. Thank you.